Hello, everyone. Hello back. Sorry, we just had a technical glitch there, but we have back Dr. Tunkel, and he's going to continue where he stopped with his beautiful presentation. Dr. Tunkel, you can go ahead again. Sorry.
No, well, I'm sorry too, because in the full screen mode, I don't realize that when I'm offline. So we now have an idea to use the handy to that you can reach me if I'm not longer online. So this probably was the last slide where we lost the audio connections, and perhaps we're going to start from here. We're back. The relining procedures. I told you that we, after autologous bone augmentation with the bone plates, we use a VR procedure during the implantation. And what we found in a little study that we made is that we have, due to the shell technique, only 5.2% of bone resorption due to between augmentation and implantation. And when we insert the implants and we do the GBR procedures, no more bone resorption of the autologous rebuilt bone did occur. And at the end, we had we show in the CBCT scan, there's the DBBM particles are perfectly integrated. We didn't do a histology, but in the CBT scan, these were perfectly integrated in the bone augmentation. And that's why we really are quite satisfied that we can use this method to keep the volume after a longer time of after the implantation. In this case, we did again soft tissue management procedure to gain fixed mucosa, and that's what we found there after prosto, a very nice crestal bone level, and you can see the DBBM layer on top of the bone augmentation, and we have a nice crestal bone level at the implants. So what we found in our study is that we had 5.2% resorption between augmentation and implantation, and of course, due to the relining procedures, we had 17% more bone gain after the procedure. This is the patient I showed you 3 years after the implant procedure, and I had the chance to do a CBCT scan of the lower right mandible side, because I did another implantology procedure on another side, and you can see a perfect bony envelope where the implant is inserted in. You see the relining layer, and we have a very, very nice and stable augmentation area after 3 years. Does this work in the long term? We have a hint for that by the study by Chapuis, which was published in 2016, which was a 10-year follow-up of the von Arx and Buther study with the where they did the bone blocks and the GBR procedure in one step. And after 6.9% resorption between augmentation and implantation in this patient group, which they could examine after 10 years, they had only 0.8% resorption between implantation and 10 years. So after what we do now with our patients, we did the relining procedures, we make a 3 to 5 years follow-up of the implants, and these are the first 20 patients we saw after 5 to 10 years, and of these first 20 patients, we had just one case of more or less severe bone loss in the crestal area, and though it might sound a bit like an excuse, this is a patient with a severe periodontitis. I did the perio therapy myself, and this patient didn't show up for any supportive periodontal therapy, either in my office nor in the office referring dentist. So of course you can't prevent a real bacterial problem, a bacterial peri-implantation due to the relining procedures. But the problems 3 to 5 years after augmentative procedures, which is due to loss of augmented bony structures, this is something we can avoid using the relining technique. How far we can go with the combination of these both techniques, I will show you in one case, which I like very much because it's really a severe defect here. As you can see, we have a quite good attachment level distally of the first premolar, and then we lose up to 7 to 10 millimeters of bone in the first quadrant. And what we did here is we did the shell technique with autologous bone first, and later on the relining procedures. The X-ray on top on the left side is before extracting the second premolar. You can see that the second premolar on the distal side has about almost 100% attachment loss. So this one was extracted, and between the second and the first premolar, we have an almost perfect attachment level, and we can only augment in the vertical area up to the attachment level of the neighboring tooth. So we did a small sinus floor elevation. I again did the shell technique with autologous bone plates buccally and lingually, and autologous bone chips in between. We waited for another 4 months, and afterwards we opened up, and again you see only a slight resorption, a perfect healing result. We insert the implants, but again afterwards we do the relining procedure, so we do the GBR and the DBBM particles with the collagen membrane, and let this heal for another 4 months. After 4 months, we do something for the keratinized and fixed mucosa. We do an apical reposition flap. You've seen that before twice. And after prosto, we see the results. We see perfectly bone gain, but the most important thing that the crestal level of the implants is on the same level as the attachment of the first premolar. So we reached a perfect vertical position again. And on the X-ray, you can see where we came from. You can see a slight bony line where we started the augmentation, and we have up 8 to 10 millimeters of vertical augmentation here in this case, and it's perfectly working here. The problem about autologous bone blocks, they work very, very well, but the big step is the bone harvesting. And I think a lot of dentists out there say, okay, I would like to do these procedures, but bone harvesting might be a risky procedure, damaging the nerve or something like that. If you look at the studies, we had 2 studies here, one by Yasha and one by Kane, that measured the distance from the cortical external area to the canal. And in these studies, we usually have in more than 99% of the patients, we have more than 3.2 millimeters. Why is the 3.2 millimeters so important? Because using the microsaw, the insertion depth of the microsaw is 3.2 millimeters. If I have a look at my own patients, I really have to see that, at least in Eastern Westphalia, where I live in Germany, the distance is not that big. Usually we have 2.4 to 3.6 millimeters, but there are several patients who have less than 3.2 millimeters. And that's the reason why we have to be careful with bone harvesting. And a second thing very seldom is taken into consideration is how does the bone harvesting area, how does it heal? Because if you have longer in your office, I'm now 13 and a half years in my office, and I see patients again and again where we have to do a second bone harvesting. And that's not that easy. And we have more complications with the second bone harvesting. And Anton Skulia made a very nice study, a very nice review, where they had a look on the regenerative capacity of the bone harvesting areas. And though he found that in 89% the volume is regenerated, but this is depending on the initial size of the defect. Of course, the bigger, the less regeneration we have. And what you can see from the numbers is that we have only in 9% a healing without any concavity, in 25% of a light concavity, but in 62% they had a profound loss of contour. And as you can see from the Curie technique, you usually harvest a quite big amount of bone, and that means the soft tissue collapses on the area of the bone structures, and therefore we don't have a very nice regeneration. And if you have a look on the two X-ray pictures I show here, these are second bone harvesting CBCT scans. And you see on the left side, we have only about 1 to 1.5 millimeters of cortical bone lateral of the nerve canal. And even worse is the right picture. After the first bone harvesting, the area of the canal did not heal at all with the cortical plate. So it is a very dangerous bone harvesting now with very high danger for damaging the alveolar inferior nerve. And that was a problem about 4 years ago. A company gave me 2 allogeneic bone plates and said, try this. You're doing the shell technique, so try these allogeneic bone plates. And I decided, okay, I will do so. And I was looking for the right case for it. And about 1 year, they were just in my cupboard in the office, just in the drawer, and I didn't use these plates. And then came a patient, which was quite similar to the X-ray I'm showing here. It's not that patient, because I'm using this patient now, it is better documented. But he had 2 vertical defects in the mandible, and I had to try to rebuild this, but I couldn't get 2 blocks in this patient because we already harvested 1 block some years ago, and it was not very well healed in that area. So a second bone harvesting was not feasible, and we couldn't regenerate both sides with just 1 bone harvesting. And so I decided in this patient, I used the allogeneic bone plates. This was the second patient I did it the same way, where I augmented one side with autologous bone plates and the other side with allogeneic bone plates. And so let's see how we do this. In this patient, I harvested the bone from the left side and augmented the area with 2 autologous bone plates using autologous bone chips. In the lower pictures, you see on the right side, we used allogeneic bone plates, but the chips in between the bone chips are autologous bone chips. That's important. I use autologous bone chips in the area of regeneration, and the allogeneic plates are just for the stability of the volume. This is then panoramic X-ray directly after the augmentation procedure, and this is the CBCT scan 4 months after the augmentation procedure. And what you can see here, this is the autologous plate side. You see a very nice regeneration in the CBCT pictures. And on the other side, again, we see a very of the allogeneic side. Let's have a autologous side on top. And the lower pictures show the allogeneic side, and even very good integrated and very stable results. And in these pictures, you can see something which is quite typical for these cases. The autologous side, the plates are a little bit better integrated. Yes, so they look a little bit more integrated, but we have slightly more resorption on these sides. And on the allogeneic side, we have almost no resorption, but the plates are a little bit less integrated. But nevertheless, all plates are usually perfectly so healed that we can put the implants, and we do the relining procedures again after the implantation. So I hope you can still hear me. That's why I look from time to time on my phone. Otherwise, you have to phone me again. This is the panoramic X-ray after the implantation, and this is the second stage surgery procedure 4 months after the implantation. Again, we do the Casangian vestibuloplasty to gain fixed tissue. Can you give me a short message that I'm still, the audio is all right?
Yes, doctor, we can hear you.
Perfect, thank you. So we do the Casangian vestibuli to get fixed tissue. We insert the healing abutments, and this is the X-ray directly after the second stage surgery. You see very nice integration of the relining layer here and very, very stable bony structures. And this is the situation after the prosthetic procedure. And again, you see very nice and stable situation. So this was something which I considered a very, very interesting way of gaining huge amounts of bony structures and not harvesting so much bone. And now I show you the first 7 cases we did in this way. This was patient number 1, I told you, the one which I started the procedure with. And always you can see the same patterns of healing. You see a slight more resorption on the autologous side, and you see a slight better integration of the autologous bone plates. But nevertheless, in all these patients, it was no problem to insert the implants. We had every time a very nice healing result. This is patient number 3, where we did the autologous plates on the upper picture series and the allogeneic bone plates on the lower series. This is patient number 4. First time we did it in the maxilla. Again, here's more pronounced. We have more resorption in the upper picture and a little bit less integration of the plates in the lower pictures. And this is patient number 5. So this is very, very nice results. Of these first 5 patients, I show you some numbers in the next slides because we did a small study, a retrospective study on these patients. But this is, for example, patient number 6 is a case I like very much because on both sides we have really a perfect healing result with a perfect way, really nice looking bony structures on the autologous and the allogeneic side. And this was patient number 7 I did so far. Again, very, very nice healing on both sides. So we did the analysis of the first 5 patients. I have to explain these tables a bit. Of course, we differentiated between the autologous and the allogeneic patients, and you see an average sign and a maximum augmentation. Average, we measured 2 in all patients. We measured 2 implants, and we built an average of the 2 implants, and we measured the site where we had the biggest amount of augmentation procedure. So if you look on the horizontal table, the autologous side was an average in the initial, the width of the crest was 4.1 millimeters, and in the area of the maximum augmentation, it was 2.8 millimeters. The augmentation was then 5.7 millimeters in average and 7.3 in the side of the biggest augmentation. And between the end of the augmentation and the implantation, we lost 0.3 millimeters in average and 0.4 on the side of the biggest augmentation. And after relining, compared to the time point directly after augmentation, we gained 1.8 millimeters and respectively for average and for maximum augmentation. And compared to the allogeneic side, you see that we have a little less resorption. That's what I told you from the pictures. We have only 0.1 or 0.2 resorption. And the relining, again, we have a gain of 0.7 millimeters. And we find quite the same numbers on the vertical table. We augmented the complete vertical defect, which was on average on the autologous side 3.9 and on maximum 5.5. We see in the vertical field slight more resorption, 0.3 to 0.5, which is a little bit more than on the horizontal. And we see again the gain of the relining procedures. But what we can summarize here is that we have almost no difference between the autologous and the allogeneic side. We have almost the same numbers, and that really shows that this might be a very, very feasible way to avoid big autologous harvesting procedures. So I told you I've so far done 11 patients where I did this thing in split mouse, and all 11 patients were healed very, very well, and we could integrate them very well. And if you ask me now, that's what I usually ask. So what do you prefer now, the allogeneic bone plates or the autologous bone plates? I say, I do both. And I let the patient decide. I tell them, we can harvest bone from your mandible, or we can use bone from another person. And there are some patients who say, I don't want to have a second wound. I don't want to have a bone harvesting of my own bone. And these patients decide to use allogeneic bone plates. And there are other persons who say, no, I don't want bone from another person. And these patients say, we do autologous side. And there's just one thing I changed in the procedure because if we do big augmentations, we need quite a lot of autologous bone chips. And that's the point where we have some kind of harvesting again, even though we use allogeneic bone plates. And so after the first cases have been very well performed, I changed the protocol because I use allogeneic bone chips as well, but I use it in layers. On the bottom of the defect, I put allogeneic bone chips, you see in the left picture, and on top, I always use autologous bone chips. Due to this, I can avoid a membrane because the autologous bone chips in contact to the soft tissue are absolutely no problem in healing. And I don't need that much autologous bone anymore. I usually harvest directly in the area of the augmentation. And this is a change which makes it feasible in every area of the mouth to do this procedure with the allogeneic bone chips and not harvesting huge amounts in the retromolar area, even of just scraping amounts in the retromolar area. This is my final case, and I really like this case. This was the case which completely convinced me that the allogeneic bone plates work perfectly. It's a patient with multiple aplasia, and I did patients with aplasia before, and I did it with the autologous bone plates. And one thing I thought with the patients is that the resorption rates in these patients were quite high. So we always had some problems inserting the implants after 4 months, and we always had to use GBR procedures even before we started the relining concept. In this patient, I again planned to use autologous bone plates, but I told him we might also use allogeneic bone plates. And we started with a CBCT scan, and what I saw in the retromolar area here is that it would be very hard to gain autologous bone plates because there is almost no bone. And so I changed my idea, and I told the patient, okay, we just use allogeneic bone plates and we scrape autologous bone from the retromolar area. Nevertheless, I tried to get from the left side a bone block, a bone plate, but during the drilling process, I realized that I perforate to the lingual part, and I knew if I try to get out the bone, there's a huge risk of a fracture of the mandible. So you see the incision lines of the bone block in the postoperative X-ray, but we didn't get a bone block there. These are the 8 areas where we'd like to insert the implants. As you can see, there's almost no bone in these areas. So we knew this would be a very, very big allogeneic autologous bone augmentation. So let's have a look on the clinical pictures. We did the allogeneic bone plates. We just used autologous bone shapes. In this patient, we harvested from the right and from the left retromolar area. And this is the mandible with 3 areas of bone augmentation. And here we have the maxilla, again with 3 areas of bone augmentation. In the area of the first premolar, we were able to insert the implants. We just made a GBR procedure there with the collagen membrane. And of course, we did sinus floor elevation on both sides too. This is the panoramic X-ray after the augmentation procedure. And again, we waited 4 months until we inserted the implants. And this is the healing result. And this is almost perfect. I really was quite impressed of the healing. It's no problem now to insert the implants. We have almost no problem with resorption here. If we look to the maxilla, we see that we have a little more, the integration of the allogeneic bone is not that good, but nevertheless they stuck to the local bone, and we could do insert the implant, and we could do the relining procedures in the maxilla too. This is directly the X-ray after the implantation. And here we have, again, the second stage surgery, again with the soft tissue management. But I like to emphasize the view on these pictures, because in these pictures you can have a perfect view what happens to the relining layer. I show this one a little bit bigger, and you really see that the DBBM particles are very well integrated, and the implant is really very well integrated in the tissues, and this is really a very nice way to have a very nice bony structure around our implants. We did the soft tissue procedures at all implant sites, as I already showed you, and this is the patient after about 5 to 6 months after the procedures of the prosthetic procedures. So this case really convinced me that I have a very nice way with the allogeneic bone plates doing the shell technique, not harvesting so much bone, and giving all patients the chance. And perhaps some of you will say, this is my chance in my office to do bigger augmentation procedures without doing bone harvesting. And I really like this case. It's really an impressive one. So this is almost the end of my presentation. This is the end of my presentation. I hope I could show you some ways how I think about regeneration and augmentation. I think there are several more procedures which can be done, and it depends on what you did in your education and how you learned it. And there are other procedures I don't do perhaps, and you do, and you can be successful with it. And all these procedures, that's something we want to show on our platform. And I would be really happy if you join us there and have a look on our platform. And hopefully I was now online with complete audio. And again, I apologize that you couldn't hear me for such a long time, but this is probably the way regenerative biodiversity works. We have so many methods, we have so many nice things we can do, and I really love to do these procedures. And of course, we can answer questions now. Hopefully, due to the audio slip, you didn't switch off your to the information. If you like, you can answer some questions.
Dr. Tom,
we're still online probably now.
it's a beautiful work. Very nice presentation. We have a question here from Dr. Pavel. He's asking, when you use the bone plates out of the bottle, what company would you recommend and why, and which ones do you usually use?
We have, I use the bone plates which are provided by Botis in Germany. They are sold by Straumann Biomaterials, and but I know there's, at least in Germany, there are 2 companies who sell these bone plates, but I use the bone plates by Botis. Have
you used the bone rings technique before, or did you use
the bone rings?
Yeah. You personally?
No, that's something I doubt a bit the bone rings. I have to be careful with that because there's something we can see that complete bone blocks, allogeneic or autologous, heal less favorably than the plates. And as I've learned the plate technique, the shell technique, of course I prefer the shell technique. And so the bone rings, in my opinion, are a full block transplant, which is even in a worse situation due to the implant in between. And I think the healing is worse than the shell technique. If I want to do implants in the same step with the augmentation procedures, I use the shell technique as well. I put my shells, so I see where my crest is going to be, and I insert the implant afterwards in between the 2 shells.
Dr. Pavel is asking, well, have you used the ZEPF bone ring technique? Is that different? Or I think it's the same.
I just saw publications. There was a publication about 1 or 2 years ago where they made an animal study comparing autologous rings and allogeneic rings, and they could show that they had only regeneration in the bottom part of the ring, but they had, even in the autologous bone rings, they had no regeneration in the upper part of the rings.
There's also
this technique.
I have a question for you. With the extracted tooth roots used in vertical alveolar ridge augmentation, I think the article was by Dr. Frank Schwartz in 2019, last year. Have you ever used the roots to?
No, I have not.
As well?
I found this very interesting because of course, this material we just have, and but I think we are at a very early step of using these routes. So far, Professor Schwarz has just shown that it might work, but we have to get some more studies before we can start this in daily practice. So I don't use it, but I'm really interested how this goes on.
What's your thought for the future? What's your thinking about blending in more of these techniques with the material? What do you think is going to be coming up here?
Well, my hope is a bit, but this hope I have for 20 years now, that we will go more to growth factors or things like this, that we are able to use growth factors, combine it with biomaterials, and therefore enhance regeneration. And but I read my first book about tissue engineering in 1999, and I found this completely interesting. And I really thought we would much further with that nowadays. But nevertheless, I think and I hope that in some way we will use these materials.
If anyone have more questions to Dr. Tunkel, we'll be very happy to. So start with your question. You can share. Dr. Barfel is asking about the company, Botis.
Botis, yes. Botis is, you can find them on Facebook or Instagram too. It's spelled B-O-T-I-S-S. Yeah, it's a German company for biomaterials.
I'm not sure we have it still in the US, so, like I've asked a few times. I'm not sure if we have it in the United States, like here.
I'm not sure.
I don't.
I have to, for example, there are plates in Italy. I don't know if it's a governmental regulation which is different from Germany. You have to contact them if they sell in different countries. I don't know why they're different in the European Union, but it's so far.
I think recently they got the FDA approval, not yet in the market, if I'm not mistaken. But Dr. Sandra is saying excellent presentation. It is. It's a beautiful presentation.
Thank you.
Any more questions from anyone? What is your most common technique that's used now? Hey.
It's for the smaller defects. It's which is about 50% of the procedures I do. It's GBR with collagen membranes, and for the bigger defects, I think it's really half with autologous and allogeneic bone plates because the patient decides. So these three techniques are the techniques I usually use.
The bigger techniques, you were saying, which techniques again? Sorry, you were cutting off for a second.
Sorry, I didn't understand.
Techniques, Dr. Tunkel, you were saying for the bigger defects, technique again? You were cutting off for a second.
With the bigger defects, I use the shell technique usually. We have half of the patients choose the allogeneic bone plates and half of the patients choose the autologous bone plates. So we do both really equally.
Beautiful presentation, beautiful work. We loved having you. And,
thank you. And I'm very sorry for the audio problem.
No.
Couldn't see that off.
It's very understandable, Dr. Tunkel. Your work is beautiful, and hopefully we'll see you more often. And there are going to be more questions coming up in the next probably a few hours. So we'll be happy if you can answer them or type them down. That'll be very interesting. We'll keep in touch with you, and we'll hopefully have you more often on us. GIS.
Thank you very much. It was really good.
Thank you, Dr. Tunkel. It was a pleasure. Bye, Doc.
Goodbye.